Hi again. How's everybody doing? Good. We are going to have just a conversation around a few things, and then we'll invite audience participation and questions as well. But really want to talk a little bit about a kind of broader commentary around the field of global health investment, so private sector investment in global health, and understand John's perspective on that. Look at how this kind of growing private sector health field is presenting new opportunities for women's ownership and employment and empowerment. And then lastly, try to tackle a little bit of this issue of reverse innovation and seeing how what we're seeing in these developing country contexts can be brought back to developed economies like the U.S. To look for ways and reasons to enact policy changes, system changes that will help us adopt those models. So that's just a little bit of a framework of what we'll discuss, and look forward to welcoming your questions. So we'll start out with private investment in global health. So as I mentioned earlier today, we did a landscaping and interviewed about 30 impact investors in health to try to understand their thoughts on this sector and this field. And heard a lot of optimism, a lot of people who are seeing really promising trends, demographic trends, increased urbanization, increased access to technology, as well as kind of trends amongst big institutions. So a public sector who is realizing the need for private investment, as One Family Health shows, big multinational companies who are really looking at these countries as places of real growth. And so my first question for you, John, is, do you share in this sense of optimism? Do you feel like you're seeing this amongst the investors and organizations you're working with? And it might be helpful to do a little bit of background of your perspective so folks know what lens you're looking for.
Sure. So I'm a founding partner of something called Total Impact Capital. We're an impact investor. If you look at Beth's chart that she showed of the I can't remember the purple, green, and I can't remember what the other color was, blue, but sort of the spectrum of different potential investors in healthcare. Beth put herself in sort of one of the green columns. We would span both of the green columns. So we work with Calvert Foundation on deals that are, I guess, what you would think of as impact first, but we also work on commercial first, but always with an underlying impact rationale. So always with the idea that these are investments that have both a social as well as a financial metric. When you ask the question is, should we be optimistic about the potential for healthcare investment in the developing world, I think the general macro trend is absolutely, and that's the feedback you've gotten before, and I think there's a very good reason for that, which is one of the sort of iron laws of healthcare economics is that as countries get more wealthy, and we see a lot more wealth being produced in the developing world these days, the share of the economy that goes towards healthcare rises. And as countries get older, the share of the economy that goes towards healthcare rises, and of course you're seeing both those trends occurring in the developing world. And so, at a macro level, the opportunity is absolutely there, and we do see that in the specific areas where we work. So, for instance, if you look at the Investment Fund for Health in Africa, which is the sort of commercial first impact investment arm that we work on, it was a $75 million fund, and now it's just about to close its second fund, which has a target of $250 million, and the first close will probably be over $100 million. So clearly there's a lot of interest in that, and the first fund, it invested in health insurers, it invested in health facilities, it invested in medical distribution, and it'll likely, it's made 7 investments, it's exited 3, and based on its current valuations, it should easily exceed its target return rate of 20%, maybe get close to 30%, which these days is a very good return. And I think a lot of major investors would be very happy with that. So I think that the optimism is justified. I think the challenge comes to, all right, you can create a fairly effective clinic that serves the middle class in a city like Lagos or a city like Nairobi. You can create a health insurance system that's focused on the working class. But how do you reach the types of people that Lila and Gunther were talking about in remote areas of a country like Rwanda or Zambia? And how do you do that not just in a sustainable way, but in a way that would attract capital to achieve the scale that's necessary to bridge that gap? And that's the challenge where I think the first green box and folks in that area really need to focus their attention.
Mm-hmm. No, I agree. I think we heard a lot of that, and this need for better organization of capital, and taking capital that has different aims, donor money, impact investor, kind of commercial capital, and blending it to try to attack some of those problems.
I would say one other point, which I think Gunther referenced, which is a major challenge for trying to serve those markets, is the transition from a purely grant-funded model to an investment-funded model. And that, that creates a lot of disruptions. Ultimately, I think that's the only way you're going to attract the capital that's necessary, but it's not an easy thing to do. And a lot of entities have stumbled trying to make that transition.
Mm-hmm. Yeah, that was actually my next question too. This private sector kind of burst is coming into a field that has been dominated for decades by donor funding and by grants and government support. With this kind of new, fancy, shiny social entrepreneurship, impact investing trend happening, what are the tensions you're seeing between kind of the old system and the new, and where have those clashes been most evident?
Yeah, those tensions are hit on a number of levels. I mean, at one level, there's a fundamental cultural shift between a funding model that rewards need versus a funding model that rewards performance. And how you get managers, both at the middle level and the high level, to say, look, we got to focus on creating surplus and showing that we can earn profits, as opposed to we have to show how difficult things are and how in spite of that we're doing some good work, but things are not that good. And I think that's a cultural shift, both in how you present yourself to the world, but also how you act and how you think about where you're going to put your resources. Do you put your resources into trying to reach new customers, so that you can show that you have a growing market, that you can, for instance, with One Family Health, you can show you can get to sustainability? Or do you put your resources in trying to do one thing very well, so you can say, look, we can do this one thing very well, and maybe we can do, with a little more money, we can do 2 things and 3 things, but don't think about trying to do 250 things or 500 or scaling up to be nationwide. So I think there's a cultural shift. The other challenge that we've seen, I mean, we work with Beth and the Calvert Foundation with the Medical Credit Fund, which provides loans to physicians and clinics through local banks. And it has been a real challenge, a challenge I think we've overcome, but a real challenge to get local banks to really understand this market and really to bank these businesses, as opposed to do what banks in developing countries often do, which is just manage payments and not really try and invest. And that's something that I think, again, where the investors have to believe that this is a business that can scale and can be sustainable, can provide return, as opposed to believing that this is something that always will require some sort of embedded subsidy. And so in some ways, you have to, the folks who are running these enterprises have to change, and the folks who are thinking about funding these enterprises have to change. And I guess I was focusing on the investor side of the equation, but that also goes to the donor side of the equation. And donors have to think hard about, are we putting our money into something that has a path towards sustainability and scale, or are we just going to put something into something that is constantly going to be out there with a begging bowl? And like you say, if you're going to capitalize on this environment, you have to think about doing it in the former model. Mm-hmm.
Absolutely. So let's turn to kind of what that macro vision is doing for opportunities for women and women's empowerment, and what models have you seen that are taking that lens or looking at building their enterprise or building their models to really increase ownership and employment for women?
Yeah, well, I think we saw a number of models here where you think about these models for women at the sort of pharmacy owner or health station owner, and the opportunity for women to take a lead role with sort of a sort of small scale clinic, the way that One Family Health identified. I think there are 3 other ways that are worth discussing. One is, and this was touched on earlier, but it's something that we're looking at, is the opportunity, especially with universal health care, which again, as Gunther mentioned, is only in existence in 2 countries, but hopefully that'll change. And it can change incrementally. It doesn't have to change all at once. But for the opportunity, especially with the demographic situation with midwives, where midwives are, in most countries, elderly and on the scale retiring, to give young women an opportunity to get the training and get the equipment they need to become midwives and set up one-person businesses to make that happen, and to provide a financing vehicle that gives them the funding to do that. Now, of course, if in a normal model, if I give a woman a loan or a man, and I'll get a little bit to how gender, I think, plays in one of your later questions, plays, we have to think maybe differently about gender than we have, not just in the developing world, but here as well. But if you're talking about a person, and I'm going to give that person potentially a $1,000 loan to get the training and the equipment they need, and they're going to go out to the farthest reaches of, say, a country like Ghana, how do I collect that? Even if the person wanted to pay me, do I have to send someone out? Basically the cost of collecting that will be worth the cost of providing it. Well, if that person is getting paid by the government through universal health care, we can have a system where the government checks off some of that money to fund the debt service, and the rest that goes into this woman's mobile health account, mobile payment account. They're the equivalent of their M-Pesa or their MTM money or whatever it is. And that way, you can have a very efficient way of servicing that loan and a pretty good credit, because as long as that woman is accurately, midwife, is accurately delivering the service, and the government's confident that those services are being delivered, they are going to pay. Maybe a little bit late, but they will pay, and that's a very good credit. And that's the type of program we're actually looking at in Ghana. Where Ghana has, with universal health care, with a commitment to pay for deliveries and pay for midwives at deliveries, they have a serious problem recruiting the number of midwives necessary. And the idea would be to say, all right, let's create a program through the Midwifery Association. They would be our counterparty for the loan, provide a loan to them, they would provide it to the women, they would provide the training, and the repayments would come from the reimbursements for attended deliveries. So that was one way. The other way is, we have seen, there was a comment that Kamaroga made about how thin the number of women were at the top in healthcare organizations. I would say, and this is not scientific, but anecdotally, when I look at a lot of the borrowers, for instance, for the Medical Credit Fund, when I look at a lot of the potential borrowers for the Africa Health Infrastructure Fund, when I look at some of the, Fola Layola of Hygieia, the CEO of the largest health insurance plan in Nigeria, is a woman. It does seem to me that at the upper ranks of growing health enterprises, you see a number of women. Some of these are physicians who've made the transition from physician to manager. Some of these, many of these businesses were family businesses, and the man was the physician, and the woman became the business manager, and ultimately a business manager of a small clinic, that's not an exciting job. The business manager of a hospital, that's a more exciting job, and that's a job that could be a role model. And then the third way that I think there's real empowerment is at the patient level. When you think about the health services that are delivered in the developing world, I just think about one of the clinics I went to in Nairobi, in Makare slum, and there was a line out the door. It was a really difficult clinic, but there wasn't a man among them. There were lots of children, but the line, maybe 30, 40 people, was all women. And so, as women have choices, as women have the ability to take control of their health care to a larger extent with some of the tools that we're talking about, that's very empowering. They potentially don't have to wait in line all day, if in fact they have, or don't have to walk all day with their kids, if in fact there's access to health care that's closer, if it's more efficient, if they can, have a health wallet, so they know that the services that are covered, and they can show up and instantly that services are paid for, and there's in essence an electronic medical record that describes what's been done, so they don't have to redo it all again. I think to many extent a more efficient health system is going to be extraordinarily empowering to women who spend in the developing world a tremendous time, in a dysfunctional system today.
Mm-hmm. I think those are all great points, and I think there is great reason to kind of, and Marla has been pushing us to do this from the beginning, is really look across the whole value chain and understand the different points that can be empowering and inclusive of women. One of the things I saw recently in the New York Times was an article around how the middle class in the U.S. is evolving and shifting, and how most of the growth of kind of middle class jobs is in health and education, most of which are occupied by women, which is really changing the kind of income dynamics in U.S. households. And was curious to see if you think similar trends are happening in these developing countries, where you're seeing women with more economic empowerment, women with, who become either the employees or the employers in these businesses, and how that's changing kind of the power dynamic in households.
Yeah, I think that's a trend in the developing world that's far beyond just healthcare. I mean, I think as countries become more developed, as there are more opportunities, as enterprises grow, as there are more opportunities not just for entrepreneurs, but also for people who work for big companies, for people who work in government, you're seeing women with many more opportunities than they used to have, and women in higher level positions than they used to have. And I think there's certain, I can't speak to how that affects the family dynamics in every particular case. I think it's an adjustment that a lot of people in countries that did not necessarily have a culture where women were seen as taking on those roles, just like our country didn't necessarily have that culture a little while ago. I think that probably does create disruptions, but it's a fact, and I think you're seeing more and more of that. As like I say, if you look at Fola at Hygeia, the CEO, Harvard trained. I don't think anyone that I know of who deals with her thinks of her as a woman. They think of her as the CEO, who happens to be a woman. And I think you'll see more and more of that throughout the developing world. But I do think that your point about what's happening here sort of raises the point I was going to make before about how we need to rethink gender. There was a mention that there's a big nursing shortage in the developed world. Of course, there's a massive nursing shortage here. And that's drawing a lot of nurses from the developing world, which only exacerbates the nursing shortage in the developing world. But part of the problem with nursing in this country is it's vastly female-dominated, which means you are trying to provide a fundamental service with only half the population. This gets a little bit to how I think the story that Susan said at the outset. The midwife who said, "I'm going to work with you," and the doctor said, "No, of course you're not." I saw that repeated. My first job out of college was working for a healthcare management consulting firm trying to help hospitals become more efficient. And invariably, we would work with the nurses. And the nurses would constantly report this dynamic where they spent, all day with the patients. They knew what was going on, and then doctors would do their rounds and write up the instructions, and often, not always, often they had little relation to what really needed to happen. And there was this huge disconnect because nursing was seen as not a profession that partnered with physicians, but as a subsidiary profession. And of course, as a profession that men wouldn't go into. And as long as those two things exist, we will have a dysfunctional healthcare system. There are many, many things that have to be fixed in our healthcare system. We talk a lot about all the problems in these other places, and we'll talk a little bit about ways that those can affect it. But changing this dynamic between doctors and nurses and creating a situation where nurses are partners with doctors, where the nurses at the top of their profession are equivalents of doctors at the top of their profession, and where nurses are not presumed to be women, I think goes a long way towards addressing a lot of the shortcomings we have in our current healthcare system.
Yeah, that's a great transition into thinking about this concept or kind of movement around reverse innovation and understanding how models in developing countries can be adapted to work in developed economies like the U.S. And so, what are some examples of this reverse innovation that you've seen where there's a model that has been kind of incubated elsewhere and brought back here?
Yeah, we've talked a lot about the sort of the ability of mobile to make a real difference in the delivery of healthcare in the developing world. And theoretically, I see what's happening in the developing world and see what some of our clients are doing, and then I go to the doctor here and I'm filling out a form and I'm wondering why am I doing this at all? I think there's real opportunity to take those types of technologies and find ways, and I don't think it's easy, but to apply them in this country. One company that we work with started in Mexico, provided wellness to Mexican companies, really wellness to the Mexican Fortune 1000. But they saw a real opportunity with the Affordable Care Act to try and create a app, because they were developing an app for the employees of their Mexican customers. But they said, this is helpful in Mexico, but where it would really be helpful is for Spanish speakers in the U.S. who are having such a tough time interacting with the healthcare system here. And so, they're doing tremendously well. They've had tremendous take-up. They've got real interest from major venture funds who see the opportunity, is to create an app that would work in the U.S. to help Spanish speakers navigate the insurance system, which frankly, I actually don't even know. So I was looking at the videos, and their videos are all in Spanish, but people were translating me, and I was like, wow, I've learned a lot. But help, and they're very slickly produced by Spanish speakers in Mexico who speak Spanish the way Mexicans typically hear Spanish, and so they're going to do others for Dominicans and others for other parts, and they're culturally relevant. They help identify who are the physicians in your area who speak Spanish, how you get to the different healthcare programs that might be there that would serve your population, all the sort of wellness tools that you would find on many of the e-wellness sites, but again in Spanish, and not just translated into Spanish, but written by people who are native-born Spanish speakers, from the ground up, and I think that type of innovation really has tremendous potential, and tremendous potential to keep people from being caught in this, in our dysfunctional system that really is not designed. Well, I don't think it's designed really to serve anyone, but particularly serve marginalized or people outside of the mainstream. One last stat I'll say that was very interesting to several of the potential investors in this company. In California, 40% of the workforce speaks Spanish at home. I mean, they're not just, that's the language they would want to talk about their health issues with. 5% of the doctors speak Spanish at all. And so, that's a huge unmet need, and that's just one state.
And how, there's everybody knows there's so much shifting in the U.S. healthcare landscape today with the Affordable Care Act implementation, and curious to hear if you have thoughts on how those shifts have benefited nurses, midwives, community health workers, and kind of brought them into the system more actively as health professionals, or if not, what are the big remaining kind of regulatory barriers to their inclusivity?
Yeah, I mean, I haven't seen studies lately that would say different, but my view is probably not. And it's they probably haven't changed things because these are very embedded, the issues I talked about before about the role of physicians. And I mean, it goes back to the way doctors and nurses are trained. And in my mind, there has to be a fundamental revamping of that for us to achieve the healthcare potential. And that's why, again, the developing world has a lot to teach us. Because in the developing world, you don't start with the assumption that it's all makes sense. Start with the assumption that it doesn't make sense, and we have to think about, I'm thinking about, again, the nurses in Rwanda. Start with the assumption, all right, we have this crisis. We have to think innovatively about how we take lower skilled nurses and put them into the system. Here we start the assumption, it's, because a doctor goes through hell to get trained and get their degree, that means that they instantly, once they have that degree, know all, and and can basically dictate to any nurse what exactly should happen. And I think that whole thing has to come down at some level. That's only, I've focused a lot on that education piece. There are a lot of other pieces about the way that our healthcare works that in my mind are very dysfunctional. Obviously the pay per procedure versus the pay for outcomes, which again, we talk a lot about performance-based payments in the developing world. Why don't we do more of that here? Some of that is in the Affordable Care Act. The inability for information to be shared between different providers. Again, we've all had this experience of filling out the very same information when you go from one physician to another, and you're like, wait a minute, didn't I put that in? Isn't there everything else we do in life, my banking, my banking, that information's spread through every ATM in the world, and yet my, my health information can't go from one provider to another. All that stuff, I think, has to be changed, and it's tremendously difficult. I think one thing that health reform and what's happening sort of makes it that such a premium because the system won't survive if I guess the way to think about it, change will happen because it has to. But I think it'll be we're not anywhere close to what has to happen in that regard.